Stereotactic radiosurgery is not for everyone. Each patient's circumstances are unique. Each patient diagnosed with cancer has a particular kind of disease and an individual history upon coming to Radiosurgery New York. Each patient has a specific site or sites of disease. Prior treatment, sensitivities to agents, and procedures are significant factors which must be taken into account. While this presentation is about the beauty of radiosurgery is not for everyone. If you have an interest in stereotactic radiosurgery, even if you've had prior chemotherapy, surgery, or radiation, you should discuss your case individually with the doctors at Radiosurgery New York. Only after going through an intensive, informed consent process which describes the risks, benefits, and alternatives of therapy should a patient make his or her final informed decision. This program will inform you about a non-invasive cancer treatment called radiosurgery, specifically stereotactic fractionated radiosurgery, and how it may be an option in your fight against tumors in virtually any part of the body, including the brain and prostate. Radiosurgery New York at Cabrini Medical Center in the heart of New York City. People come here from across the country and around the world for this uniquely innovative cancer treatment, first brought to the Western Hemisphere by pioneering radiation oncologist Dr. Gil Lederman. To underscore the importance of researching treatment options before settling on one or more, it was decided to have someone who undertook an extensive cancer treatment search on behalf of her brother Todd briefly tell her story. Todd had been told he had but 6 months to live.
My brother was diagnosed with hemangioparasitoma, metastatic and disseminated, meaning he had many lesion sites, after originating with a meningioma 20 years prior. And he did 4 rounds of chemotherapy with no result, other than hair loss, bad results, side effect issues, lack of energy, nausea, all the things that most chemotherapy patients experience. And so for 8 months, he went home and worked 40 hours a week and spent time with his family while I tried to find him another option, nationally and internationally. And that's when I stumbled upon, gracefully, with your treatment, the radiosurgery. And when when I told him about it, he was in disbelief, and he thought that in order to have efficacy, you had to have side effects.
Why did he come to New York for treatment? It's far away from home. There were a lot of options closer to home. What brought him to New York?
You, basically, honestly. He looked at the tape, and it was a great option, and you accepted him as a patient.
Did he feel there were promises made to him when he came?
No. No.
Was he told that this was definitely going to work?
No.
Before you came, we spoke about our extensive experience with hemangioparasitoma, correct?
Yeah.
And what did I tell you?
One patient, and with one site, one primary site. Treated him, and it was successful. So that also gave us, finally we met somebody that had dealt with hemangioparasitoma, because no one else had. He saw a doctor since he was 18 years old. He had a brain tumor when he was 18, a brain tumor when he was 23, a paraspinal tumor when he was 28, and then disseminated metastatic hemangioparasitoma at the age of 39. So he saw doctors throughout his life always telling him, you're going to die, 6 months to live. You can be paralyzed. You might not be able to walk. And you didn't say anything like that. You said, this is what you have, and this is what we can do. And it worked.
We asked Tana to go over questions and answers with Dr. Lederman, questions and responses she became familiar with during her quest. They are offered here in the hope they will provide you with a clear picture of what radiosurgery is and whether or not it may be a treatment option for you or a member of your family.
Radiosurgery, why the term radiosurgery?
Radiosurgery is a historic term. Radio means radiation beam. Surgery means it's defined or precise, like a surgeon would use a knife. But radiosurgery is totally non-invasive.
Why is this radiation different than the standard radiation that patients hear so often about?
Standard radiation often will radiate large areas of the body. So to get to a cancer or tumor area, a doctor will have to give more tissue radiation to the right, to the left, above, below, behind, and in front of the tumor. Radiosurgery in our hands allows us to focus the beam on the cancer area and minimize the harmful effects to the healthy tissues. Because of that, we can give a higher dose, and because it's a higher dose, we can give fewer treatments, and because of a higher dose, fewer treatments, it's more precise, less side effects, and it's more effective usually than standard radiation.
And I'd like to ask some questions about brain fractionated radiosurgery. What does the fractionated part of that mean?
Fractionated means we're dividing up the dose. Some of the original treatments, like for brain tumors, were with an instrument called a gamma knife. A gamma knife had screws would go in the head, and usually just one treatment was given. Doctors have known for about 80 years that if you divide up the dose of radiation, it makes it safer for the surrounding tissues. And we elected more than a decade ago to fractionate essentially all the radiosurgery. Fractionation means it's totally non-invasive. There's no screws in the head. We use a relocatable head frame that can come on and off when necessary. It's painless for the patient. And also there's less harm or harmful chances for irritation to the surrounding healthy tissues, for the brain and for the body.
What type of diseases do you treat?
In the brain we treat primary and metastatic cancers. We also treat benign tumors. The benign tumors are acoustic neuromas, which are a benign tumor on the hearing nerve, meningiomas, which is a benign tumor usually on the coverings of the brain, and pituitary tumors. Those are the most common benign tumors of the brain, and we have quite an extensive experience with each. And often meningiomas are in very delicate spots where open surgery would not be successful in completely removing the meningioma. Those spots are around the base of the skull or brainstem, or around blood vessels or delicate nerves, sinuses. And actually, fractionated radiosurgery has very high control rates non-invasively to control or to shrink the meningioma. Pituitary tumors affect many people, and then there's the cancerous tumors. Cancerous tumors that are metastatic or cancers that start in the body, go through the bloodstream, and end up in the brain in general, and those are tumors that affect 250,000 Americans a year. So it's the dominant type of cancers of the brain. And then there's cancers of the brain itself, like glioblastomas. So there's a whole variety of tumors, and most benign tumors have a superb prognosis. Most patients will be effectively treated with radiosurgery and have a pretty normal quality of life.
This noted Israeli orchestra conductor had begun to lose his hearing on one side because of a growing acoustic neuroma. Gradually losing his ability to hear his string section, his future in music became doubtful. Treated by Dr. Lederman with fractionated radiosurgery, the tumor stopped growing and even regressed. His career has long been back on track.
Cancerous tumors are different. Cancerous tumors often affect the brain very harshly, and we use fractionated radiosurgery to try to stop the tumors or to make them go away.
Can you do chemotherapy and this treatment concomitantly?
It can be done, and we encourage that in certain cases. Tumors like glioblastomas, brain tumors, we often will give chemotherapy and radiosurgery together.
What are the competing options for the patient?
Well, there's surgery. So some people have surgery, like for acoustic neuromas. The problem with surgery is that most people end up deaf in that ear and often will have facial paralysis on that side. Up to 1% of people can die on the table during surgery. We have the largest experience in the world treating acoustic neuromas with fractionated radiosurgery. Also, we use the lowest biologic dose, and our program is totally non-invasive. 95% of our patients keep hearing, and 80% of patients keep hearing at the same level that they came to us with. So it means that most people will keep their hearing, and almost everyone keeps facial function. So the risks of treatment have dramatically fallen with fractionated radiosurgery compared to open surgery. And we believe as well that fractionated radiosurgery is better than single fraction type radiosurgery with screws in the head.
What's the expectation for the experience with the patient during treatment?
For brain radiosurgery, there's a head frame, a non-invasive head frame that fits over the ears and the nose. And there's fiducial markers, so when we scan the patient, we can find the relationship between the head frame, their head, brain, and the tumor itself.
The relocatable head frame, while snug, is comfortable and is only worn for a very few minutes during each visit. The precise fit gives the technicians the ability to accurately repeat the relationship between the computerized radiation beams and the targeted tumor for subsequent visits. The same accuracy is performed for body radiosurgery by placing the patient in a snug, individualized, stereotactically molded body frame with fiducial markers to permit precise initial targeting and retargeting for follow-up treatments.
It's a very rigid position, although it's a pain-free position, and it's not claustrophobic. The beams come from many different angles, and they all converge on the cancer area. So it allows the dose to the cancer area to be very intense, and because it's coming from so many different angles, the dose is blurred out to the healthy tissues. So the healthy tissues usually don't have a significant adverse effect. Fractionated radiosurgery really allows us to treat any site, anywhere from head to toe. We usually consider the body everything below the neck, and in fact we can treat cancers of the neck, this mediastinum or center of the chest, lungs, liver, pancreas, kidney, spleen, lymph nodes, urologic sites like bladder, gynecologic sites, and even the extremities. We were the first one, to the best of my knowledge, worldwide to treat extremities with radiosurgery. And the guiding principle is the same, to try to focus the beam more on the cancer and to diminish the dose or harm to the healthy tissues, and sometimes to escalate the dose to try to have better control. The dose is critical. There's a curve called the dose response curve, and as you go up on the curve, there's a greater response of the cancer to the treatment. So very commonly we'll use a higher than normal dose, and we would expect a greater than normal response of the cancer where we aim the beam.
And how about kidney cancer? I know that's difficult to treat as well. Do you have experience with that?
We probably have the largest experience worldwide treating kidney cancers. Kidney cancers historically are thought to be resistant to radiation. And it's true, with standard radiation it doesn't respond very well, but it again is that slope of the curve. And when we give higher doses per fraction using radiosurgery technique, the control rate where we aim the beam is actually quite high. And we've treated kidney cancers in the kidney, beyond the kidney, in lymph nodes, liver, lung, bone, and even in the brain, with high degrees of control.
And what do you mean by control?
Control means that where we aim the beam, that the tumor or cancer stops growing, shrinks, or disappears. Once the cancer has traveled, often it will keep on traveling. You can say, why should you treat someone when the cancer is traveling? Well, sometimes people have symptoms, pain, suffering, bleeding, and they wish to be treated for those symptomatic reasons.
With body radiosurgery, how quickly is there pain relief?
Some people come to us with severe and intractable pain. I recently had a patient a couple weeks ago who couldn't sit down because he had so much pain. We gave him 5 treatments, and by the 2nd treatment he was pretty much in relief, and by the 5th treatment he had stopped all his narcotics. So very commonly we see great relief of symptoms. I had a young man from India here at age 27. He had a kidney cancer diagnosed at age 25, recurrent at 27. I was called up to see him in his bed. He was on a morphine pump. He had a tube in for feeding. His family was around waiting for his death. And that was the only site of disease, by the way. The cancer had come back in the kidney bed. We treated that site as a last-ditch effort. Within 2 treatments, he was up, around, walking. By the 3rd treatment, he was discharged home, and now it's 6 months later, he's back to work, fully functional, pain-free. So we've seen some dramatic results with radiosurgery. Obviously, every case is unique, and there's no guarantees. But we have seen a lot of benefit in patients where we thought there'd be very little chance of benefit. So we're doing several things that are different than normal or out of the ordinary. One is to shape the field of radiation, either with IMRT or with other technologies, to shape the radiation beam to better fit the cancer. We're using a stereotactic frame to hold the patient in position and allow us to focus the beam, and then we very commonly escalate the dose. So those three things together, I believe, allow much better results than standard radiation.
Let's talk a little bit about efficacy with this type of treatment. Let's start with the body radiosurgery efficacy. What can be the expectation of the patient with just one primary lesion?
If the cancer has not spread, if the cancer is in a primary site, hasn't traveled, then the goal of treatment often will be to try to cure the patient, to treat them, to eradicate the cancer before the cancer spreads. One thing we haven't talked about is retreating areas that have already been radiated, but we probably have the largest experience retreating previously treated sites. We often treat sites that had surgery, had chemo, or even had radiation before. And that's a big plus for patients because often the other treatments haven't worked. The patients are stuck with an enlarging tumor and have very few options. So reirradiation, especially with a very focused beam, allows that patient a second chance of controlling the cancer, or a third or fourth chance of controlling that cancer after other treatments haven't worked.
And when you're talking about retreatment and the radiation didn't work, are you speaking of standard radiation or are you speaking of the fractionated radiosurgery?
Most commonly it's with standard radiation. Standard radiation fails approximately 50% of the time for lung cancer. So there's many patients out there who have treatment and yet the cancer unfortunately comes back and they need some other solution. We like to follow up patients. Many people ask us, how do we follow the patients after they leave radiosurgery? And we usually ask for reports and CAT scans of the treated site about every 3 months to continue to follow the patients. We have data managers who follow every site that we treat with the purpose of helping the patient know what happened to their cancer, helping the family know what happened, and also in general the medical profession and future patients would like to know what is the success rate or control rate when we treat a specific site with this technology. Most cancers can be treated, although I can tell you that of all the patients who send us their scans for review, we refuse about 50% of the time. And we refuse to treat patients when we think there's better methods of treatment, or that radiosurgery wouldn't make a significant impact on the patient, or maybe the patient isn't in good enough physical shape to benefit really from radiosurgery. So each person is really unique.
Perhaps no one case points to that uniqueness more than the case of the gentleman who had colon cancer in 1998.
Shortly thereafter, had metastasis to the liver despite chemotherapy. We treated the liver, the metastasis went away. He developed metastasis a year later in 2000 to the lung. The metastasis went away. And then afterwards developed in 2001 prostate cancer, which we treated with brachytherapy and radiosurgery, and he's in remission from all sites. He's cancer-free to this day, even though he had metastatic cancer to the liver and lung and a prostate cancer, all's in remission.
And when do you treat lung cancer?
We treat patients with lung cancer in a variety of different circumstances. Sometimes when it's newly diagnosed, we use radiosurgery to escalate the dose to go to higher than normal doses. The reason is that standard doses often fail, and so it must be that local control has to be better. If we can control the local cancer better, it's very possible that there'll be a higher rate of cure. Sometimes lung cancers spread and patients have very few options to treat the metastasis, or the outside of the lung sites, whether it's the bone, the lymph node, the liver, or elsewhere. And radiosurgery can pick out those sites, send beams of radiation in, and very commonly control those sites. One man came to us with a huge mass in his lung. He was told it was inoperable. He came in a wheelchair. He could barely breathe. He was on oxygen. We gave him radiosurgery to that mass. It hadn't spread anywhere. They sought a second opinion about surgery and actually had the mass resected after radiosurgery, and the pathology showed no cancer. It had been totally obliterated by the radiosurgery, and he's cancer-free to this day 3 years later. Many people with lung cancer will have obstruction of the airways and they have shortness of breath or cough or even bleeding. Those can be very serious symptoms. And so retreatment will often allow a high degree of controlling those sites of cancer where we aim the beam.
Tell me a little bit about the woman with pelvic cancer.
Oh, we've treated many women with pelvic cancer. I think the one you're referring to had a cancer of the anus, but she didn't know it. It actually had spread to a lymph node in her pelvis. She was having intractable pain in her right buttock area. That mass was found, and it was only after an extensive search did the anal primary get found, biopsy proof. We treated with radiation and chemo, and then used radiosurgery to treat the lymph node. And she's been in remission now about 3 years, cancer-free today.
And there was another woman that presented with sarcoma that you spoke about.
She had a sarcoma of her left humerus. She had surgery to remove the humerus and replace it with one of her leg bones, her fibula. She had chemo and radiation. She had a nodule in the lung, and she just couldn't take the thought of more treatment and more disease. It finally grew to massive size. It was occupying almost all of her thorax into her abdomen. She had chemo. We encouraged her to remain on chemo. She and her family came to us and told us that she'd rather die than have chemo. And in fact, we treated her. We gave her 5 radiosurgery treatments to the sarcoma in the chest, which was massive. It was growing through the diaphragm into the abdomen. The cancer shrank dramatically, and she had quite a good quality of life after radiosurgery, and in fact even got married.
And what type of guarantees can the patient expect?
Unfortunately, there are no guarantees, and there's no promises that we make other than to try to do our best.
And is cure mentioned with this treatment at all?
Sometimes cure is mentioned. For example, men with prostate cancer, 90% of the patients we treated are cancer-free. So we never use that 4-letter word, or almost never use that word. But the goal, obviously, for localized cancer in the primary site is to try to control or cure that person or have a long disease-free survival.
What about the patient being radioactive after treatment? Is that an issue?
The only patient